come back to order, and we're going to get started here. I suppose you guys are Meridian, right? All right, just make sure we're on the same place. So thanks for coming. Thanks for our patience on adjusting the schedule. And we will try to proceed on through here as quickly as we can. If you would, just state your name and who you're with, and you're recognized and to present. Yeah, just pull that up close there. I don't think, is the green light on? There you go.
Oh, needs to, there we go. I'd just like to recognize the chair. Thank you very much for inviting us in the committee. My name is Sean Kendall. I'm the Vice President of Business Development for Meridian Health Plan.
My name is Aaron Scheich. I'm a Business Development Analyst with Meridian Health Plan as well.
Great. We'll get right in. Just a brief introduction of who Meridian is, what we're about. Our mission statement, to continuously improve the quality of care in a low-resource environment. We are physician-owned, Dr. David Cotton, and family-owned. The Cotton family owns us, so that makes us a little unique, privately held. We're committed to quality, innovative technology, member and provider satisfaction. Our vision is to be the premier service organization in government healthcare and to be the #1 organization based on quality, innovation, technology, and service to our members. We're very proud. Meridian Health Plan has been recognized by NCQA in the top 20 Medicaid health plans. Actually, our Michigan plan is #9 in the country, and our Illinois plan is #10 in the country. We do several Medicaid and government type programs. We do Medicaid, we do Medicare, we do both traditional Medicare. We do a dual eligible program, special needs program. We also are part of the CMS demonstration project for the integration of the duals in 2 of our markets today in both Michigan and Illinois. Something that we pride ourselves is on quality. Here is demonstrated our rankings in all of our states: Michigan #9, Illinois #10, and our Iowa plan #38, the first year that they're eligible to be ranked. And you can see here in some select measures that we were able to increase the quality of care and move to the higher 90th percentiles in a lot of different measures. So we're very proud of that. Just a comparison of why we think a fully capitated managed care program, the services that you get and compared to a primary care case management program or a fee-for-service program, all the different services that the health plan would be able to provide compared to a PCCM or a fee-for-service program. We believe in a fully integrated system, like an integrated care organization where there are no carve-outs. Let the health plan, the managed care organization, do a holistic approach to the member, cover all the pharmacy benefits, the behavioral health benefits, even the long-term support services. We strongly believe that fully integrating the care for that member and not having a bifurcated system allows you to do this and will greatly reduce the cost of care over time. You can see in our different markets, there's different, just like it's been said before, one Medicaid program, you've seen one Medicaid program, in different states have different levels of integration of the care. Something that's very beneficial to a fully capitated managed care program is the predictability of cost. You've heard some numbers thrown around about what the future of costs are going to be. There's some studies about what cost was. You can see that there was a 7.3% growth curve over a certain amount of time. So we provided some data from our health plan in Michigan that shows what the capitation rates in Michigan had changed over that last 5-year period for 2 different populations, the TANF population, mostly your moms and babies, and the ABD population. And you could see that the capitation rates in 2010 compared to 2015 have gone up, are well below the cost curve in comparison to what was going on in the rest of the country. Another thing that we could talk about is you wanted to talk about real results. Michigan went to a fully capitated model back in 2000. There was a study put out by the Lewin Group, and the full study can be provided, that showed what the rates on traditional fee-for-service were compared to the rates in the first 5 years of the program, first 4 years of the program for the managed care entities. And you could see that by year 4, there was a 20% reduction in the cost of care compared to the fee-for-service program to the managed care program.
And just to clarify, because it's come up many times previously, when you're showing your medical MCO rate there, that's including all administrative costs?
That's all in.
Yep.
That is correct. So that is our full capitation payment that we're full risk for. The way that,
So, I mean, let's just go back to that for just a minute, okay? 'Cause I just want to make sure, again, I'm the slow learner group, so 20%, okay? So we have $6 billion a year, and again, I'm the slow learner group. 0.2 times 6 billion, by my math, that's $1.2 billion per year.
well, this was going from fully unmanaged program. There was no case management for these members before, so there was a lot of opportunity for healthcare management and getting the right. So 20% is the maximum that you would see. Now, you have some kind of management program going on here today, so we'd see these numbers reduced. But this is what you can see going from a fully unmanaged population to a managed population, the amount of opportunity that's there in properly coordinating the care, getting the right care in the right place at the right time. Less costly care, not in the EDs, but in the provider's offices instead. One way that we're able to do that and bringing up the point of why you would want to go with a managed care entity versus just boosting up your own case management program is they're very heavily invested in technology. Meridian, we've developed our own managed care software where it's available to our providers online as well too, where they can get information in real time. They can check eligibility, they can check the PCP, they can check the services, they can check well visit opportunities that are out there, all available in real time to our providers. And it's all built internally in our own system. So we have one system that all the information going from claims to quality to provider credentialing, all in one little package that everyone in the company can work on. It's also available to our providers online in real time. And it really helps with efficiencies of scale, really helps in tracking and reporting measures and taking advantage of every opportunity you can when you encounter a measure. I can give a brief example of, we do call campaigns to welcome our members to the plan. And when we're doing those campaigns, our system will alert us if there's any well visit opportunities for the member available. And it also does it by a family, by a household, so we don't have to call the same household more than once. And so it'll bring up, if we're talking to Mrs. Jones, it might say that her son Tommy needs a well visit. It might say her other son John might need a lead screening. So we're able to coordinate that. We can potentially get the PCP on the line at the same time, do a three-way call. If transportation is needed, transportation is a big barrier in healthcare, and especially in the Medicaid population. We can coordinate transportation with that member as well too, if they need mileage reimbursement, or if they need public transportation, or if they need an ambulatory trip of some kind with a sedan. So we're able to do that all in our managed care system and really help coordinate the care. But we need to be extremely efficient because this is a low resource environment that's out there, and we need to do it with as little administration as possible. So we're able to do that with technology. Something that we do in taking that holistic approach with the member is our most difficult population would be in our care coordination programs. Typically, you'll see that some of the numbers that are thrown out, that 20% of your population is driving 80% of your costs. Well, we've dug down deeper where you can see that 5% of your population is driving about 50% of your costs. So working with those most difficult populations and getting them into our care coordination programs and really developing this interdisciplinary care team. I think it was mentioned earlier today, as well as, it's working with the member, working with their PCP, working with any specialist, but also we bring in a behavioral health team, we bring in our pharmacy. We're lucky enough to have our own PBM as well too, so we can see all that information is transparent. And taking a purely holistic approach to that member. And even if there's any family members that they wish to be on this committee, we can do this telephonically, we can do this in the field. We have community care coordinators that are out in the field working with the members. Some of the members are very difficult to find. The addresses are old and they're out of date, or they've moved on, or they don't have an address that they really use. They might have just used the local DHS office as an address. And so we have community workers out in the field trying to find the unable to reach members as well, and trying to do these interdisciplinary care teams meeting to try to engage them, develop a plan of care, and then a care coordinator will work with that member to make sure that they're instituting that plan of care that they're part of. It's a person-centered approach. They need to buy into it. They need to be a part of it, and working with not only them, but also their primary care and their specialists. We strongly believe in the patient-centered medical home program. We have had a program in place to support our providers on patient-centered medical homes since 2011. We invest significant dollars to support our providers in that because we believe in preventive care, we believe in developing a home for the members, and we believe in supporting providers for that, because there's not so you can't bill for a care coordinator. There's no code or CPT code to bill for a care coordinator on the Medicaid side, at least. So we have administrative support that we can do both internally. We also have monetary support for providers that are accredited by a national body of some kind, either NCQA or URAC, or working towards that accreditation if they can demonstrate that they're working towards that accreditation. So we have different programs and different levels of how integrated and how supportive they are in that medical home process. So we strongly believe in that program, and we've seen great results in comparison to our providers that are PCMH accredited versus providers that are not PCMH accredited. We see quality scores go up for providers that are PCMH accredited, and we also see utilization go down on a PMPM basis. So it delivers higher quality at a lower cost by that patient-centered medical home model. So we support it. We've talked a little bit today about value-based contracting. We want to try to get away from that traditional fee-for-service model. A lot of models that we do today is we integrate a bunch of different models. We have a fee-for-service model that is supported with an administrative payment for patient-centered medical home, and then also a pay-for-performance. Oh, running out of juice here. A pay-for-performance model. And so that's a model that we typically start off with individual offices, but as a group, maybe into larger systems, integrated care systems, we can go toward shared savings models where we want to try to see the costs reduced, but not push that reduction purely onto the group, have them share in those savings so that they can have an interest in seeing the costs go down, but not see it's not fully on the burden of the backs of the providers. And then going towards a full risk model if they're integrated, where we can give them a set PMPM as well, and where they're fully invested in and they have every interest in seeing the cost of care at a certain amount as well too. So we're seeing that we have agreements in that in place like that today, and we see great opportunities to do that here as well. Critical success factors, we see improved quality of care, access to care. I know access to care was a conversation that we were talking about before. We've had great success in delivering full and comprehensive networks out to all of the states that we deliver services for, with our mixture of boots in the ground, provider representatives, network representatives out in the field working with our providers, helping them navigate the system, reducing the administrative burden that is put on. Think of a typical HMO and all the authorizations that are involved and all the hoops you have to jump through, and trying to reduce those burdens by working directly with those offices. And we see overall cost savings of that program. We monitor for fraud, waste, and abuse. That's something that we're heavily invested in, and we have technology to help identify fraud, waste, and abuse and work with those providers and try to eliminate potential upcoding issues or never events of other type of items in fraud, waste, and abuse. Reduction in inpatient admissions, and then also reduction in ER utilization. That is a big factor with the Medicaid program. You see a lot of the population going to the ED for their primary care visits, preventable visits, going to the ED instead of to their PCP office. We're trying to work with them to identify their PCP and get them back in to see their primary care physician in an office setting instead of the more expensive, costly ED visits. That's all I have for my presentation.
Okay, we've got Representative Gray, you've got a question?
Yes, thank you, Mr. Chair. Just real quick, could you go back to the slide that showed the 2000 to 2004 difference? And I guess my question on that, is that really 2001 through 2004, or is it supposed to be 2011 through 2014?
No, this is
That's that old?
This
Okay.
was in Michigan. This is information specific to Michigan. They went to full managed care in 2000. So
Okay.
this is showing the managed care rates that were paid to the MCOs from 2001 through 2004.
Okay, and then just help me understand real quick, because I mean this slide's impressive. Help me understand, are you comparing fee-for-service on the same people you're comparing them on Medicaid? I'm trying to figure out how you got $177 in 2001 and $161. Are we comparing apples to oranges? Are they the same population? And if so, how is it possible?
Well, you're comparing those that are in fee-for-service, that are not on a managed care program, that are not being actively managed and work with a managed care organization. So those that were not transitioned over to a managed care, so just on traditional fee-for-service, working with the state program.
Okay.
To those that were transitioned over to a managed care program, and the difference in costs and the savings that were realized by fully managing that population versus a traditional fee-for-service program over that time.
Okay, and then the final question that goes with it is, that particular population that in the first year went to $161, was that particular population, what were they in fee-for-service the year before? were they the same? Were they higher or were they lower? Because I know each demographic, each population is different. So I guess my question is, I kind of feel like we're comparing apples to oranges a little bit. I'd like to know what the cost was for that population that got transitioned the year before.
Okay.
Thank
I don't
you.
have that available. I can see if it's a
Let
Lewin
let
report
me,
that
let
I'd be
me,
happy
let me
to
try
follow up.
and, I've got the same question now that we're doing it, which is, if I said population A was 107 years old or older, and population B was 20 to 30, and you told me those differences, I'd look at them one way. If you said population A was everybody that resided in Livonia, and population B was everybody that resided in Mount Clemens, I would look at those numbers very differently, because everybody in Livonia is almost identical to everybody in Mount Clemens, but people that are over 107 years old are much more expensive to manage than people that are 20 to 30. So I think that's what Representative Gray's trying to get at here. Is it just, commonality of geography, so it's really the same kind of people, or is it people that are really, really sick, and of course they cost more, and we left them in fee-for-service? That's what we're trying to understand.
Right. They moved all the populations over. So it was the TANF population, the ABD population they moved over. But thank you for the local Michigan references, by the way. But we can get the full report for you and share it with you so you can have it fully available. It's a Lewin report from a third party, so.
Yeah, Charlie's pretty proud of folks from Michigan coming down here for some reason. I guess in Michigan, are they all under managed care now?
There's approximately 1.6 million in managed care. It's the majority of it. The only ones that are not in managed care are those on the waiver services. They have not put that in to the managed care organizations, but they're looking to. And also, behavioral health is still a carve-out. Michigan currently only covers about 20 outpatient visits into behavioral health. So there still are some carve-outs and some opportunities. We've seen our plan in Illinois has a full integrated model where it's behavioral health, long-term support services, and that's where we really see the greatest opportunity for managing the care of that population.
Those numbers that you have up there, 100, 210, 170, what are those numbers today in Michigan?
Well, we have that. Is that on the before? So this is in the populations where you see it today, a lot less in the TANF population. ABD population is a lot higher, more services.
So it has increased dramatically in the last 10 years
Well,
for the ABD?
I can't say that for a fact. I don't know if that, I'd have to look at the report to see if, what population that was in there. But I believe, I can't speak to that. I'd have to pull the report, the Lewin Group report. And we
And
can provide that full report for you.
That first 4 years, when you were contrasting the difference in the folks who transitioned, what was the mixture in the population in Michigan then? Did they start out with 50-50, or was that about 10% that was managed care? What type of mix were we looking at there?
I'd have to get that information for you.
I mean, like Representative Gray said, that's a pretty impressive slide if you, and as Representative Collins said, if you could really utilize those type of savings. And we are sitting here, and I guess the final question I'd say is, as you look at Arkansas's healthcare systems now, you have mentioned and are aware of the efforts that we've made to try to reform and to do some efficiency from a state mandated perspective. Do you see similar opportunity, or not as much in a traditional fee-for-service that you saw when you did this in Michigan?
I think 20% over 4 years is probably aggressive, but I would definitely think there's opportunities with a fully capitated managed care program to increase the degrees of healthcare management, which would reduce the overall costs.
And
What percentage that would be, I'd be guessing at best.
And do you all have some contracts or doing some work with Arkansas now?
We do not.
Okay. All right. Any other questions? All right. Thank you all for coming. Great.
you.
Appreciate the presentation and willingness to sit around here and listen to all this incredible stuff. Yeah. Senator Ingham, you recognize?
Now we got just a little break here after after hearing Representative Collins. I brought to mind the late great writer Louis Grizzard from Georgia when he said, you can move down here, you Yankees can move down here, and you can marry our women and you can take our jobs, but just don't tell us how you used to do it in Cleveland.
Senator, I was told early on that my answer to the question, how long have you been in Arkansas, is I wasn't born here, but I got here as quick as I could.
That's a politician for you. Okay. moving on, we're going to go to Aetna. You all, the folks from Aetna, that's always the first test to get the technology to work. It's kind of a self-serve operation here. So if you ladies would introduce yourselves and tell us who you're with, for the record, you're recognized. No problem.
So we'll go with the PDF version here.
Okay, push your green button there on the,
Oh, we'll go with the PDF version,
Okay.
so apologize for that. I'm Janet Grant, and I am a Regional Vice President with Aetna Medicaid, and I'm very pleased to have with me today Donna Checkett, who's our Vice President of Business Development, and I asked Donna to come up because she's got a unique perspective, having served as a Medicaid Director for 8 years before joining the precursor, actually, to Aetna Medicaid, Schaller Anderson. So she may be able to answer some of the interesting questions that you've been dealing with all day. So I'm going to, in the interest of time and to not be repetition here, just breeze through a little bit of intro related to Aetna Medicaid, and then I want to call out some of the statistics that we put into the detailed responses to the questions from the Stephen Group, and call those out for you that I don't have on a slide, but I think are responsive to the kinds of question and discussion that we've had so far today. So first of all, Aetna obviously is a part of the larger Aetna organization. We serve almost 24 million folks all across the country, and have the distinction of being a 160-year-old company. And today here in Arkansas, we serve about 91,000 members with our various commercial products. Aetna Medicaid is a distinct unit within Aetna that is very focused, mission-oriented, focused on the Medicaid population. As you can see, our mission statement, we believe in improving every life we touch as good stewards to those we serve. Very member-centric from a member perspective, and very much focused on partnering with our state partners to deliver both quality access and affordability. You can see here our footprint. You've seen a lot of footprints today. We serve about 3 million members across 17 states, have responsibility for managing long-term services and supports in 7 of those states, including 4 states that are participating in the CMS Medicare and Medicaid integration program. You can see we've got experience really with all the various populations that are served in Medicaid. We date back to our roots in Arizona and launched in 1986, so 30 years really of experience. And Arizona was a unique state in that they approached Medicaid from day one as a full managed care program. And we serve really all the populations today in Arizona, and have served long-term services and supports there since the late 80s, and have the distinction now over the last about 16 to 18 months now of also serving as a regional behavioral health authority in Maricopa County, which is the Phoenix area. We serve 900,000 folks for their behavioral health needs, including about 25,000 with a first of its kind fully integrated approach for the severely mentally ill in Maricopa County. I'm going to, again, really kind of move through the rest of this pretty quickly so I can share some of the statistics. Obviously, as we've heard from all of our colleagues today, our recommendation to you is to strongly consider and do the due diligence that you're doing today in terms of a managed care approach. We have seen the benefits of this. In terms of quality, increased access for Medicaid consumers, cost savings for states, that budget predictability that you've heard a number of other folks talk about, and really satisfaction from consumers, engagement from them. And to speak to some of the concerns about managed care, that savings does not happen based on cutting provider fees or trying to set up barriers to care. For this population, it really is about making sure that services are in the appropriate setting, the appropriate services are provided, that we're reducing duplicative services, increasing preventative care, really managing program integrity in order to take the fraud, waste, and abuse out of the system, using evidence-based practices, and rebalancing on the long-term services and support side. And that is important both from a cost perspective, but it's really most important from a consumer perspective. These are lots of times our relatives that have spent down and need long-term services and supports, and they want to be in their own home. They want to be in the community, and that happens to also cost less for the Medicaid program. I'm going to talk a little bit about some of the statistics. These are all cited in our response, and be happy to again provide some of the detailed studies that are behind this. Many of these are external independent studies. So in terms of savings, you heard, I think, cited maybe by one other company today, the Milliman report out of the state of Texas that was just issued in February. That's really a very timely and I think appropriate study for you to really consider. Milliman did, in their analysis, estimated that there had been, or not estimated, documented an 8% savings each year for the state of Texas with the broad managed care approach that they have in Texas. And that equated to $4 billion from 2010 until 2014, and with a projection now of another $3.3 billion of savings this year until 2018, while also documenting improving access and improving quality. There's also cited in our response, and probably others, from Lewin. Lewin did a study back in, it is a little bit more dated, in 2009, and that was really a synthesis of the 24 different studies that had been done independently up to that date, documenting savings anywhere from, depending on the program and the population and the state, anywhere from 1% to as high as 20%. And that 20% number was from the state of Arizona in terms of their rebalancing efforts on long-term services and supports. A state that I am responsible for in Missouri, the most recent study we have there is from that state's actuary, the Mercer Group, and they looked at what the savings had been comparing the same population and what it would be from a fee-for-service perspective versus managed care. And that state, having just the TANF and CHIP populations in managed care, documented a 2.9% savings and about $48 million out of that budget. But also what was important in that study was that they also noted that the program design, and this is why it's important for you to look at the details behind these numbers, because the program design in Missouri, they admitted, very much limited the ability of the plans to deliver even higher savings. They have a carve out for pharmacy, they have a carve out for specialty behavioral health there. And they have some fixed facility costs that the plans don't have the ability to manage. So they also in that report cited that typically they see across all of the states, and I think they said about 30 states that they participate as actuaries either on the plan side or on the state side. Typically they would expect managed care delivering between 3 to 6% year over year. Rebalancing for the long-term services and supports population is a really critical area of both, again, savings as well as increased quality and choice for the members that are being served. In our own experience, again, going back all the way to the late 80s in Arizona, literally when we started that program was at 100% of folks at nursing facility level of care were in nursing facilities. And today in Arizona, that is only 24%. The state's own figures are that that's equates to a $300 million savings per year, year over year. And we continue to make inroads there. We're experiencing just over the last couple of years still another couple of percent per year that we're able to rebalance. In the state of Delaware, in the first 2 years of the long-term services and supports program there, we went from 58% being in nursing facilities to just 46% being in nursing facilities, which is a 27% improvement in that. And finally, in Florida, you heard a little bit about the long-term care program there earlier. We've been managing long-term care there just since February of 2014, and in our own numbers, the state assumed a 2-point change per year, and we have delivered a 4-point change per year, which is a 7% improvement. And for just those that we have transitioned out of the nursing facility back into the community, when you take into account that it's a differential of about $4,400 per month of the cost between nursing facility and home and community-based services, we've delivered about $8.5 million on a relatively small population that we're managing in Florida. And all of that is certainly also supported by increased quality and increased satisfaction. And I'll just end with one other statistic, and that was recently in our Florida program, again, a new program. For the first year, we surveyed our members, and an astounding 80% of those members, these are all folks that have a nursing facility level of care, either in the community or in the nursing facility, 80% felt that their quality of life had improved in that first year in the program. So those are all important factors as you continue the work that you're doing, which I, again, commend you for this kind of deliberation. I was here last week for the DHS panels. These are the kinds of discussions that, that you need to be having at this point as you consider the options for going forward. So with that, we'll take any questions.
Okay, I'll start. When you talk about the reductions in folks in long-term nursing facilities and the success that you had in Florida and other states or Arizona, you made like 100 to 25% or something. I guess what I would like to know is the total number of people in the two options still the same, greater, lower? What is are we transferring people from nursing home to home care? Or are we just making home care larger to make the percentages different?
Yeah, no, there were two factors. I mean, obviously, the population is aging, and so the overall, pool of folks, the overall pie is definitely increasing. But those are percentages of what that total population is. So, 100% in nursing facilities, now only 24% in nursing facilities. It's not increased of just increase of home care. It is both, though, transitioning folks out of nursing facilities. Also, what's really more important and the bigger opportunity, because that's very hard. When someone's in a nursing facility, lots of times they've given up, lost a lot of their supports, given up their home, et cetera. That's a bigger transition to manage, but it's really about being able to delay or prevent the nursing facility placement. So these are all folks that have a nursing facility level of care. This is not typical just receiving home health services. They have a nursing facility level of care.
And then my follow-up is, you mentioned Florida. You're involved in Florida for the
Yes.
last year or two, and obviously we've heard some testimony both about the wild stories that came out, and then now that they're saying there's just a 6% negotiated increase. I guess tell us a little bit about your thoughts on, are there providers not getting paid? Are there massive increases that are happening? What is going on in Florida?
Well, I'm not the total expert on Florida, and I appreciated Dave from Molina giving a little bit of the context there. On the long-term care side, and Florida has a bifurcated program, which, again, I would support what you heard earlier, having a fully integrated program really is the best way to manage here. But in Florida, there's a separate long-term care program and a separate physical health and behavioral health program. On the long-term care side, the rate is actually going down. With the new rates that go into effect in September. The stories that you've seen in the paper are about the physical health side of that program. Our company was not one that came forward with concerns.
Okay. Senator Elliott, you're recognized.
Thank you, Mr. Chair. I have a question on page 5. I'm over this side, way over here. On page 5, checks numbers 3 and 4 that begin engage member and then employ evidence-based. Do you see where I am?
Mm-hmm.
Okay. Because I think sometimes we make our decisions and base policies on what our experiences have been or assumptions. I would just like you to talk to me a little bit about how you use the 4th check to inform the 3rd check about cultural competence. How do you put those two things together to come up with the way you service people?
Very good question and very timely for us. Our company is making very significant investments because we recognize how important this is for the populations that we serve across Medicaid in terms of health disparities and looking at health equity. So both from the standpoint of making sure all of our practices are culturally competent, that we're training our staff appropriately, that our member materials are appropriate, that we make sure that we have translation services, et cetera, as well as we're making investments all across the country right now in focused pilots to really deal with health disparities. And so from Arizona and Nebraska, where we serve Native American populations, through, Michigan, where we're serving in inner city Detroit, we're looking at the uniqueness that we see across our members and some of those challenges, and doing pilots that we are then doing research approach on in order to bring those best practices across all of our business.
Well, do you, in order to get the evidence-based practices that inform your cultural competence part of this, is that what you're describing? You get the information through the pilots, or do you actually employ some group or some facet of folks to make sure that what you are using is indeed culturally competent?
Mm-hmm. I would say it's both. We're certainly taking the evidence that's out there.
Mm-hmm.
What we're realizing is that there's still a lot that we don't know, and we want to continue to drive toward practices that can improve health. And so it's both. It's
Okay.
certainly taking those lessons, but also proactively doing research in order to identify best practices for the future.
Well, I appreciate you're not just going on assumptions, so thank you
Right.
for your answer.
Right.
Thank you, Mr. Chair.
Okay, that's all we have on the list right now. I appreciate you all's coming down, and great job. And we're
Thank
going to
you.
move on. We're going to do a reboot of the server real quick to try to get our stuff working again,
The computer's turned off. Somebody turned off the computer, that's why.
so we're okay.
I think so. I'm gonna turn on and see.
Okay. Hey, before our next group, John Stephen, are you still here? I forgot to recognize you before we broke for lunch, and you wanted to make an announcement real quick.
Just wanted to make sure that the task force knows that the plans have all given substantive answers, and some of the budget questions are in their answers to us. So when I was over the weekend putting all this together for you in that matrix, we have all those, and those are gonna be given to you tonight by Phil. So every member of the task force will have, pretty detailed responses from all these companies. So you'll have that, so you can, read it on your own as well. And it does have, and your matrix does have a section on budget savings. So they've identified that, and we're doing our own independent analysis as well.
Yeah, and I think that's something that, again, we might want to follow up for the next month's meeting, is a report on, now that we've gotten all this data, give us a report on objectively, what do you think savings history is in some of these situations. All right. We are going to Magellan, number 8 on our item, section E. So gentlemen, thanks for coming. If you all want to introduce yourselves and tell us who you're with, you're recognized to present.
Thank you, Mr. Chairman and honorable members of the task force. I'm Glenn Stanton with Magellan Healthcare. I am currently the Senior Vice President for Business Development for the company. By way of personal introduction, similar to our last presenter, I have a variety of experiences, including I was the Director for the Disabled and Elderly Health Programs Group at CMS before I came to Magellan. So I am a recovering Fed. And joining me is Don Clare, who's the Vice President for our Magellan Complete Care program, and he'll be speaking to some of those points. And as mentioned by Mr. Stephen, we have provided a great deal of detail already, so we won't be covering that. We tried to keep it to 4 brief slides so that we can do questions. And being number 8 means that many of these things have been covered, so we'll be quick. Magellan is a fully integrated health plan. We do care coordination, utilization management, disease management for Medicaid and Medicare members directly with contracts to states. We also serve as subcontractors to other health plans. So collectively, we serve more than 52 million Americans, and we serve more than 3 million persons who are Medicaid or Medicare eligible. Those members are basically in 7 states. Like other members other colleagues that have presented today, we have a heavy focus on local operations, local employment, et cetera. But what may be different is that we provide services to states under a variety of models. And so you've heard about carve-ins, carve-outs, et cetera. We operate under any number of different kinds of models. And from our perspective, the best model, I think, follows what the governor was saying, is one that is best for Arkansas. And so every state designs what's best for them, and most importantly, what's best for the member. So in some states, we act as a fully integrated MCO. We manage physical health, behavioral health, LTSS services. In some states, we operate simply as a behavioral health vendor or a behavioral health program or an LTSS program or some combination. So we can operate under any one of those models. And in fact, in Florida, we are the first in the nation specialty health plan that only serves persons who have a serious and persistent mental illness, but we serve the entire person. So physical, behavioral, medical, all services are there. So I'm going to turn it to Don, who will give an overview of Magellan Complete Care.
Magellan Complete Care is the health plan division of Magellan, and as Glenn mentioned, if I just ask you to focus on the bottom right corner of the slide, it really focuses on some of the different programs that we do offer. And so we have Medicaid, general Medicaid TANF operations, as well as offering a Medicaid managed long-term care plan. For some states that's appropriate, such as New York, that's where we operate there. And then in Florida, much like the discussion yesterday, it was noticed that those with serious mental illness have a lot of complexities to their care needs, as well as a high cost to the state. And so we see that in Arkansas, and in Florida they saw that as well, and they recognized that they needed to be proactive in doing that. And so they selected Magellan to become the nation's first Medicaid specialty plan for individuals with SMI. And so we operate, or we manage the physical health and the behavioral health, as well as the other social needs of those members. And for Florida, that was the right decision. And so as Glenn mentioned, I think in the end, it's really just a matter of collaboration and discussion to identify what is going to empower members here in Arkansas to take charge of their care so that we can help them down the path to wellness. Should the task force decide to go with a fully integrated, comprehensive health plan, I would ask you just to look to the left. In that case, I would recommend that internal integration is the best path to improve coordination. Many health plans still today need to vendor out behavioral health. They need to vendor out pharmacy. We're very pleased at Magellan to have a broad set of internal capabilities where we have our own radiology benefits management company. We operate as the pharmacy solutions manager for over 26 states and other health plans. So we have the PBM capabilities internal, as well as our well-awarded behavioral health business. And so all that together really allows us to serve the member internally, which gives us the best chance to integrate and coordinate that care. Looking to the next slide, really just focuses on a lot of those key program design recommendations. And I think you'll see that a lot of these are very similar to some of the other health plan colleagues that they've mentioned. And person-centered care planning, I believe, has to be critical to everything. We're very pleased and proud that at Magellan, it's really the foundation of everything we've done. In fact, beyond just being person-centered, it's really person-driven. Because we come from a behavioral health background and worked our way into becoming a health plan, we've seen the power of self-directed care and peer supports. We know the power of surrounding folks with resources so that they can take full care or full charge of their health plan. And so that'll be a critical piece to whatever model is chosen. Some of the other things that maybe have not been focused on yet today, the continuous stakeholder engagement. Meetings like this, meetings with advocates in the communities, members and their caregivers will really help us shape a successful program for the entire state. And then finally, in the bottom right corner, partnerships with the advocacy groups and community-based organizations. There are a lot of great things working well already in Arkansas. We don't need to go ahead and just recreate the wheel. We need to come in and collaborate with those groups, partner with those groups, and see how we can supplement the good things they're already doing. And so we're really, we're accustomed to doing it in other states. We're looking forward to doing it here in Arkansas to help members live better lives.
So I also want to highlight a few of the things that were included in our response to the questions from the Stephen Group on your behalf, and address again the question that's repeatedly been asked about, so what's the difference? Why can't we do this ourselves? I mean, everyone has mentioned the predictability of costs. I think that's incredibly important for policymakers who have to live within the budget. I think that one has to be cautious in terms of looking at savings on percentage basis when you're looking at those PMPM costs, because the variable in there is membership. So as members go up, those PMPMs go with those members. So looking only at flat percentages, you have to look at the full benefit package, what is covered, who are the members, to really get a apples to apples comparison. One of the other competitors mentioned another significant thing that managed care companies bring, and that's advanced data analytics. So we can take the claims data, supplement it with health risk appraisals of the members so that we can get a total picture of the person, and then using data analytics stratify members so that we know if they are at very high risk, moderate risk, or low risk. And for those who have a low risk of needing high levels of care, we can provide services that can be self-directed or self-managed. So we can provide health information. We can direct them to or make available nurse lines to everyone. You can do online kinds of interactions and therapies. So for that group, you can match it to them. For those that are transitioning back, we utilize routinely family members, peers, caregivers to bridge that gap back into the community, and then identifying those that, again, we've heard the number 5% of the membership is 50% of the cost. Those are really the high cost members that need a lot of intervention, but if you can use your data analytics, identify them right out of the gate, you can make sure that they're getting the attention they need. Another thing that I don't think I've heard mentioned is the flexibility to create new services with the savings. So Magellan in 1994, in a behavioral health carve-out program in Iowa, created something called reinvestment, which meant that once we started to see savings in the program, we worked with the state of Iowa. We identified what were the evidence-based practices that were missing in the continuum, what were provider rates that needed to be adjusted, and then we pushed that money back into the community, and that has gone from anywhere from 4% to 7%. In Arizona, where we had a reinvestment program over 5 years, we put 7% of the total premium back into the community with new services, new investments. That's a win-win for both the managed care company and the state and the members, because members are getting an expanded service array, providers are probably getting paid a better rate, there are better evidence-based practices, and the medical loss ratio, that spend on the medical care, stays flat, because every 2 years the rates will be reset so that you're not losing the funds that need to support and provide providers and provide care. On the right-hand side of the slide is the success factors, and again, I think all of us have really applauded the work that you and the governor have done around gathering input, making a deliberate decision. And I think also a critical part of the success factor is addressing the social determinants of care. And so the chancellor this morning spoke about all those other things that are important to a person's health, the job, where they live, et cetera. And managed care companies have learned over time that whether or not we are paid to do it, it is in our best interest to try and engage members in other kinds of living arrangements or other employment opportunities to help them. So in some of our programs, we have something called a community integration specialist. And these are persons that are matched with members to get them access to Voc Rehab, to assist them in getting access to other community resources. These are on-the-ground people that we employ or we have providers employ to make sure that those social determinants of health are addressed as well. There are many things that you'll need to consider in the design of the program. Making sure the rates are actuarially sound has been mentioned a number of times. That's critical. Also, auto assignment with limited opt-out. So part of the reason that many of the dual eligible demonstration programs across the country have struggled is because it's a voluntary program and members don't have to enroll. And what happens is you don't get the critical mass and the program doesn't work because you can't get the scalability you need to provide the services. So assigning the members, mandatorily enrolling Medicaid members, not necessarily Medicare, and then saying you have a fixed number of days in order to change plans, gives stability to the system and allows the member choice, but creates some stability. I think with that, you've heard plenty from our 7 prior presentations, so we'll take questions.
Okay, yeah, we've got a couple on the list. I just want to, you're the 3rd or 4th one, I think, who's made mention of the fact that it's productive to have a process prior to a crisis. And I think that's really, we're very fortunate. I know a lot of you were here a couple of years ago when we had the crisis with teachers' insurance, and we had to react and go dump a bunch of money in it and then figure out how to fix it under threat of crisis. But I guess the other thing that we've learned today is a crisis is coming. With us being 49th in health and the trends of 5 to 6% growth, it's just a question of when it gets here. So I hope everybody realizes the importance of getting this right in a deliberate way, and I appreciate folks recognizing that. My question is with regard to physician access, because again, that seems to be the fact is most of the medical doctors and physicians seem very reluctant to be very excited about managed care. And would you comment on why that is and what impact you've seen in states that have done this with regard to physician access and size of network?
Again, I think it's been said previously, I think part of it is fear of the unknown. I think that in many states, physicians have not come into Medicaid because perhaps the rates are low and they're looking for that mix in their practice. And so they would like to have a mix of Medicaid or non-Medicaid, and depending upon what they're getting paid through commercial vendors in the commercial market, they're looking for that blend. I think that there's a fear that they'll be overseen to a limit that would be unacceptable. I don't think, like the others who presented, I don't think in any of the states we've done work that we've seen physicians leave the system because managed care has come in. Because if managed care is done right and the plans are supporting the physicians, perhaps providing incentives to participate in PCMHs, to participate in integrated health homes, providing physician incentives actually can bring physicians in.
The only thing I would add is we know that physicians want to do right for these members. They want to serve these members, but the economic proposition in the past has made it difficult. And so as mentioned earlier today, that the role for managed care plans today is to provide the resources and the tools that can simplify that for providers. And so if we can put staff members in their offices to help with coordination of care planning, attaching members or helping members locate the resources in the community, we can alleviate some of those burdens from offices. And so then with that, partnered with the pay for performance and those type of incentives, we know that we can help create that balance and allow physicians to treat and really help these members. And we know that that's what they would like to do.
Okay, Representative Ferguson, you're recognized.
Thank you, Mr. Chair. I'm more interested in what you spoke to begin with about you want to manage care for Medicare and Medicaid for the dual eligibles. Can you speak a little bit and explain to me, I know didn't you have a demonstration project in Massachusetts on the dual eligible population? And in doing that, are you requiring or strongly encouraging your Medicare populations to move to Medicare Advantage plans?
So yes, we were one of the first plans selected in the country with our partners Fallon at Fallon Health Plan in Massachusetts. Our company was called Fallon Total Care, and so we were part of that duals demonstration. Since then, Fallon has bought our interest out. In New York, though, we continue in the duals demonstration in New York, and we act as one of the FIDA plans, which that program name there. And so we are big believers in the coordination, not only across the care continuum, but across the governmental programs. So we are big believers, and we really see the value of that program. As far as trying to guide or direct members to the Medicare Advantage, we certainly don't try to dictate or push members that way. We hope that the benefit package that we can prepare would certainly be enough of a reason for them to join our Medicare programs.
So, I mean, of course, I really dislike Medicare Advantage plans. I think they take advantage of patients, and they pay headhunters to go out and sign these people up, and they don't know what they're getting. But so I'll move on from that. But the community workers, I thought the first person who talked said that you need to require some kind of certification for these people. And I thought that was very interesting because healthcare is very complex. I mean, I have trouble explaining it to patients sometime and all their options. What kind of training do you require for these people that you're helping coordinate care?
Well, we have a peer certification program, and in some states, peers in the behavioral health system are actually a Medicaid benefit. And so peers in those programs have to be certified. The state has to get that certification program approved by CMS so that those persons who are assisting the members actually have trained. There's basic background, criminal background checks, all those kinds of things. But there is a training program that we have those peers and those community workers who are supporting members to do that. But I think that the important thing to think about is that those community health workers or community health or peer bridgers, they're called different things in different states, are that they're not providing health care. They're really trying to help somebody navigate their way through the system. So, and it's someone that has experiences that are common to theirs, either a family member. So for children and youth that have severe emotional disturbance, we often employ family groups to actually act peer-to-peer to help other families navigate the system. For adults, we may use adults. There are some states that have peer-run programs. So there is training, there's basic background checks, but they're not doing healthcare, but they're really trying to help people navigate their way through the system.
All right, just a second. Push your yellow button. Now try it. You have completely destroyed it. All right, I'm going to turn it off now. Let it stop. Now push the yellow button.
Okay, I get it. Yeah, I mean, but as you know, I mean, the health system's very complex, and I mean, like I said, I know a lot about healthcare, and I have a hard time helping people navigate plans and providers and all those kind of things. So these people have nothing in common. They have no training other than they have some commonality in what they've.
Well, no, they receive training in the system array. And again, everyone that would be receiving that service through Magellan would also have a care manager. So the care manager from Magellan is coordinating with the member, with the providers, looking at the case, looking at the needs, looking at what they are receiving or aren't that should be. And then these community health workers actually can go and help a family member get someplace to an appointment. So they're not acting as a health guide. We have paid health guides who are trained clinicians, but they are supporting people in the navigation of the daily, trying to get from place to place in the healthcare system.
Yeah, I just thought the idea of having, even if it's 40 hours like you do for home care workers, to have some kind of training certification was a good idea.
Mm-hmm.
Senator Cooper, you're recognized.
Thank you, Mr. Chair. One thing I haven't heard much of today is connection with the prison recidivism rate. And somewhere in there, there's a piece of the puzzle that has to do with severe mental illness in regard to that. And I think I heard the other day that one state, I believe it was Ohio, and I don't know if the data is correct or not, but I heard they have a 10% rate where ours is about 40%, something along that line. Is there any connection that you know of data-wise in what you do that would have significant impact on that recidivism rate?
I do. There are a couple of things. One is diversion. What we find is oftentimes persons with a serious mental illness end up in the judicial system when they really don't need to be there. And so there is a national program, CIT training, which is done with first responders, mostly the police department. We have someone from Arizona who works as a consultant with us across the country. And we provide that CIT training for the community, for those first responders. So the first thing is to try and not have people end up in the county jail or in someplace else where they really don't need to be in the first place. There is no cost savings to a health plan to do that kind of work. The cost savings is to the community, and a good health plan is part of that community. And if we can keep people from going into the jail, then we don't have to worry about them coming out and being in worse shape or not having access to medications because they lose their Medicaid eligibility when they end up in the jail. So a lot of it is front-end diversion. Coming out, we also will, through our care management system, know if someone has ended up in a county jail. And then what we would do is use bridgers to try and connect with them as they're getting released to try and make sure they're re-engaged with the program, re-engaged with their mental health treatment, because that's often what's needed to keep them from doing something that results in them being picked up again.
Do you have any data on those rates before and after?
I don't, but I certainly do within the company. We can definitely get those to Mr. Stephen from Arizona in particular.
Yep, I can get that to you.
Thank you. Thank you, Mr. Chair.
Senator Elliott, you're recognized.
Thank you. I'm over here to your left.
I'm sorry.
This morning, and I hope I characterize this correctly because I heard this about 9:30 this morning. Dr. Ron from UAMS talked about the importance of flexibility for the doctors in delivering services that are sensitive to the place, the people, and so forth. Would you just give me your quick thoughts on how that flexibility can be a part of delivery of services from the doctor's point of view within a managed care system?
Well, a good managed care system isn't going to affect the daily flexibility of a physician. What the managed care company should be doing to support physicians, and I think the Chancellor talked about it this morning, is establishing those clinical guidelines, making sure that all physicians are aware of what those guidelines are, identifying those that might be performing outside of practice patterns broadly, and providing consultation and information. Some of that you're already doing through some of the initiatives that you're trying to do here through your payment reform. So I think that the flexibility should always be there, and the support for managed care is to provide a comprehensive package of information about a case and where they're being seen outside of that physician's office so the physician knows.
The other thing I would add too is there's been a lot of talk today, or several mentions of the interdisciplinary care teams. And so as you're pulling together these care teams that really surround the member, increasing communication between providers is really the linchpin of coordination. And so as we create not only forums for them to come together, but also IT technologies that they can share call notes and make changes to the care plan in real time, all those sort of things will create the flexibility so that the member can be best served in the best and most appropriate place.
Well, just as a quick follow-up, I noticed you said a good managed care system. So does that mean, because I hear from so many doctors that they don't have that flexibility, does that mean, maybe this is a naive question, but there are bad managed care systems that's causing doctors to complain to me and to others about not having the flexibility to service their patients as they see that they need to be?
I think, as with any business, I think there are practices that are better than others. I don't think that any managed care company is going to deliberately try to restrict a physician's flexibility. Some may have stricter requirements around authorizations or some kinds of limits around practice. It's really going to vary by plan. And if Arkansas decides to go down the path of managed care, I think that it will be critical in the design of your program, what services are going to be included, what populations are going to be included, but also what the contracting process will be with the plans and what your expectations are.
And just lastly, Mr. Chair, so then, in order for this plan to be something that does incorporate flexibility, in your experience, have doctors and managed care systems and policymakers or whoever, have they all worked together to define flexibility, or is somebody defining flexibility and everybody else just has to live with it?
I believe it's improving. There was a discussion of HMOs in the 90s, and in the 90s it was a very much a us versus them type of mentality between providers and health plans. And that's not good for the members in the end. But I believe today you're seeing much more collaboration, and I believe that the incentive programs that align goals to what's best for the member is really a key driver of that. And so I believe that there's been a great shift and a tremendous shift towards that type of collaboration.
Okay, members, that's all we have. Appreciate you, gentlemen. Good job, and we're going to move on to the next presenter here, which is going to be Shared Health, Arkansas Blue Cross Blue Shield. So if you folks will come on down. If y'all identify yourselves and organization for the record, you're recognized to present. Do you have a PowerPoint there?
Yes, we do. I think we'll try to pull it.
Okay, and members, you should have a handout here that's coming around.
Thank you, Mr. Chairman.
I am Steve Spalding. I'm a senior manager with Arkansas Blue Cross Blue Shield here in Little Rock.
Hello, I'm John Cole. I'm the Chief Operating Officer of Shared Health. We're a wholly owned subsidiary of Blue Cross Blue Shield of Tennessee. And so I'm going to start off talking actually a little bit about my experience. I've been in the TennCare program for basically almost the entire 21 years of the program. I started off as a provider, so I have some unique experience. I was an employee of a wholly owned subsidiary of Covenant Health and UT Medical Center. I then was a consultant for the Bureau of TennCare during the TennCare reform implementation and also during the Choices program. So I'm definitely familiar with those programs and how those were implemented. And now I'm with Blue Cross Blue Shield of Tennessee, like quite a few of us that were at the state of Tennessee. My boss, our senior VP of government programs, was the assistant commissioner of the Bureau of TennCare at the time as well. So, we've been in the TennCare program since 1994. We've been here for 21 years. We're the only managed care organization that's actually been in the program for the entire 21 years. The last 2 years, we were awarded the best overall plan by the Bureau of TennCare. So in 2013 and 2014, we were given that award. In CIO magazine, we were awarded in the top 100 of healthcare of innovation. That's not just healthcare companies, that's all companies across the United States. And that is mostly due to our medical informatics programs. And so, we have about 550,000 members in the state of Tennessee, Medicaid members in the state of Tennessee. About 10,000 of those are LTSS. We have Also, one of the things I think I really want to talk about, we also have a dual special needs plan. In the state of Tennessee, one of the things they did in the with the dual special needs plan is they actually required the managed care organizations to implement a dual special needs plan. Now, that's very important for the LTSS population. The reason why is because about 90% of the LTSS population are dual members, and so it's critically important that you have that access, or that you are have that other side of the equation, the Medicare side of the equation, so that you can sort of track and understand everything that's going on with the member in the LTSS program. And so, in addition to that, we also operate, the children's SSI program. For special needs members, we also operate the CHIP program for the state of Tennessee, and we operate the IDD program for the state of Tennessee. And we're happy to say we've formed or looking at a strategic partnership with Arkansas Blue Cross Blue Shield. We think that's incredibly important because we understand that healthcare is local, and we really we can't just come in and implement programs that came in from Tennessee. We've got to come in, understand what happens here in Arkansas, and sort of get down in the trenches and really understand the state and what's going on here in the healthcare community.
Just a little bit about Arkansas Blue Cross and Blue Shield. You probably all are aware that we have a strong footprint here in the state. We employ about 2,500 people. We have a statewide presence. When folks talk about population management, our definition of the population is everyone who lives in the state of Arkansas. So we think it's important for us to try to help in any way that we can to improve the quality of life for everyone that lives here. You probably know that we were the only carrier that offered coverage for the exchange and the private option on a statewide basis the first year of the program. That was very important to us because, again, we are an Arkansas company that is focused on serving Arkansans. You've heard other companies come in and talk about their affiliations with other blue plans across the country. Our affiliation for the purposes of this opportunity is Tennessee Blue Cross. We did not make that choice lightly. We did a lot of work to understand Tennessee, our neighboring state, who has a lot of similarities to Arkansas as far as population and culture, and our two companies have a lot of similarities in our culture and the way that we look at things. So while those other companies will be competitors of ours if they're chosen to participate in this, we will be working with Tennessee because while we have significant experience with most of the population in the state of Arkansas, what we don't have significant experience in is the special needs population, and that's really a strong point and a sweet spot for the Tennessee people who will come in and integrate that with the other things that we have done.
Can I just interrupt for a question here real quick? Because I think you have somewhat unique experience here. So did you say you're doing Medicaid managed care in Tennessee now?
Yes.
And how many people are 500,000 or something?
500, yes.
Is this traditional Medicaid or is this expanded Medicaid or
It's traditional Medicaid.
0 to 17%?
The state of Tennessee decided not to move forward with the expansion.
So, and you obviously have the experience with the private option because you're the biggest carrier of the insurance policies. I guess what I would ask you is the same question I asked somebody earlier is, based on your experience, do you see managed care fee-for-service higher or lower cost than traditional insurance premiums?
I think we definitely see a lower cost, but
a lower cost for which?
Wait, did you say for Medicaid managed care? Do we see it for a lower cost than the fee-for-service program?
No, a lower cost between private insurance, if we're talking about the expanded population now. Because obviously, as we look at what the governor suggested, and as we look about the cost comparison between a traditional Medicaid fee-for-service approach or managed care fee-for-service approach versus what we're doing now, which is insurance premiums for private insurance?
Yeah, so I'll let Steve sort of address the expansion population. Tennessee actually did not move forward with the expansion population, but if we had to say, do we see lower costs between the expansion population generally, or a general commercial population and a Medicaid managed care population? Yes, I mean, it's substantially less.
Which is substantially less?
The Medicaid managed care.
Okay.
So if we compared it to our commercial population, it would definitely be less.
I guess what I'm trying to find out here again is what we need to know is what are the financial impacts of a decision, or if we were to look at a program that had a component that was private insurance, but also a component that was either fee-for-service or traditional or managed care fee-for-service. Mm-hmm. What would we be looking at when we compare the costs of those two alternatives? Is there another state that has expanded Medicaid and uses managed fee-for-service?
Not in the way that Arkansas has.
No, I don't mean like we've done. I'm
Okay.
saying like traditional Medicaid, managed care fee-for-service. Has anybody done traditional Medicaid expansion like that?
You know, New Hampshire's doing something like this. So they have the expansion population on the exchange, and then they have the remainder of their Medicaid population, and they're also moving in a phase 2 their LTSS population into what we'd call sort of typical Medicaid managed care. So New Hampshire's a good example of that, and I think it's working well for them.
Okay, and again, kind of for our consultants, that's a fundamental question we're going to have answered is what is the cost comparison, whether it be managed care or just traditional fee-for-service type of approach versus private insurance market. And of course, we have to take into account that it may be a smaller private insurance market if we do pull some of those people. Since I've interrupted here, I got another one. Representative Ferguson, you're recognized.
I wanted to contribute to the conversation. I think it's important to clarify in these discussions that we're comparing apples to apples, because our Medicaid population only goes up to 17% of poverty, and we've moved all the medically frail to Medicaid. Tennessee, what, do they go 100% of poverty? What's Tennessee's Medicaid?
I actually think it might be 133, but
Yeah, I know. They have a significantly higher Medicaid population rate, so it's going to include a much healthier population than our Medicaid population. So just know that when you're comparing apples to apples, you might include the Medicaid expansion premiums plus the Medicaid to get the right answer.
Well, and it's a very valid point, especially, again, when you consider what we've done with medically frail and so on. It's hard to get a good comparison.
Just as long as we're talking about some of those things, the thing that I've always scratched my head on is how in the world we could have 17% of poverty and yet have 1/4 of our population on Medicaid. That was before the expansion, which has probably taken us closer to 1/3.
Yeah, we're the same. We have 1/4 of the population on the Medicaid program. Actually, it was substantially higher. There was which is probably leads into a lot of why we don't, why we're not an expansion state. Years ago, we had to go through a reform initiative where we had to disenroll numerous members. It was a very painful process in the state of Tennessee, and so we had a much higher rate of FLP that we were or FPL that we were that the members could participate in TennCare, and so there were 200,000 people who lost their insurance. It was a very, very painful time.
Okay, you guys can go ahead. Sorry, like I say, we may interrupt again, but that was
no problem.
Oh, no problem. I'd much rather address these as they're fresh on your mind. But just to continue on, again, we think in management of the population, there are going to be a number of the residents of the state that move into eligibility from Medicaid to the private option to the exchange, and frankly, a lot of them are going to be using the same providers of medical services. So what we think is that, it is beneficial not only to the residents of the state of Arkansas, but also to the providers in the state to have some consistency and expectation in administrative processes and things like that to create more efficiency in the system, as opposed to having what we've had in the past, and that is different rules and different ways of doing things by the different sources of payment in the system. We have significant long-standing relationship with many stakeholders in the state. I'm not going to tell you that we haven't had our rubs in the past, but we certainly have worked together to get through those. We know DHS, we know the Foundation for Medical Care, the Center for Health Improvement, Medical Society, the Hospital Association, the Pharmacy Association, UAMS, Children's Hospital. We have long-standing relationships with them and the ability, we think, in the past experience of working through pretty complex issues with them to the benefit of the residents of the state. So I'm here to kind of represent the synergies that we think are beneficial to the system in consistency and integration between maybe a special needs population and then the gray area between those that are going to move from more commercial insurance into exchange or Medicaid expansion.
And so I think one of the things we want to start talking about is just what we feel are the competencies needed for Medicaid success. And so to us, any organization coming in here, basically right off the bat, they have to get their core right. We can talk about all the population health programs in the world, but if they can't pay claims, they have slow customer service, their process is difficult, then they're not going to build trust with the provider community, and they're going to continuously have problems in their population health program. And one of the things too, I kind of wanted to address, I think it was a question asked earlier about provider rates. I think there's been a lot of questions about provider rates in this. And so one of the things that happened in Tennessee, because I was a provider early on in the program, when the state of Tennessee first started, we were at about, I think we were paying physicians about 60% of Medicare, so somewhere in that range. That was in 1994. Now, that number's probably about 80% of Medicare. I think that's the state actuarial, the way it's based in state actuarial. So we've actually seen an increase in provider rates over time. And so when we look at the cost curve that's actually happened and the cost trend that's actually happened in TennCare, where TennCare was at 13% cost trend starting this program and 60% member satisfaction, and now where they have, now where they're at about 3%, about 3.3% cost trend right now. And we've seen that with actually increases in physician rates over time. So just something I wanted to add. I know it was a question that's been asked a lot, and I want to talk about that when we talk about our core capabilities. And that's something that we do when working with the physicians and working with the state, and and basically trying to develop a good relationship with the physicians. And so the other parts of the competencies for Medicaid success are just, the population health program. These are very difficult programs to navigate for the member. These are a very vulnerable population that are very difficult to navigate. And so one of the things that they have to have is sort of one care coordinator, one manager that helps them navigate all of these programs, helps them navigate community resources. We have over 400 member outreach events every year where we're going out, working with members, trying to work with them to get them involved in taking care of preventive services. And so that's critically important. We actually get right into the, I'll keep using this word, into the trenches and into the field and making sure and where the members are and working with them to try to improve their health. And that is critically important to everything we do. And then the medical informatics is also critically important to the population health. You have to understand the population, and ours has been, like I said, has won a couple of awards over the last couple of years about how we've done medical informatics and how we've stratified our population. And then quality has just got to be in everything that you do. And so I heard some discussion, some questions earlier about, can you improve quality while decreasing cost and be financially successful, I guess is maybe the way I might put it. And what I would say is we can be financially successful because we improve quality. That is the reason why we would. And so, if you were to go to a company like Apple or someone like that, or any other industry, they look at producing quality, and that is why they are profitable, and that is why they do well. And that's the way that's the way the managed care industry should be. And that's the way we try to run our organization. And so when you go and talk to people in our organization, what you are going to hear is people talking about quality. You're not going to hear a lot about, cost, even though there is always a cost aspect to how we are improving the quality. And so then, just having an acute understanding of our membership is also critically important. You know, we have to understand the social disparities of the member. I know we've heard a lot about this today, about the social needs of the member, but if you're worried about where you're, you know, paying your rent or where your next meal is going to come from, you know, us, you know, trying to work with you on your diabetes or making sure that you're taking your prenatal vitamins or any of a number of different things, it's just not going to be well received. And then, you know, the other thing is, when we think about these competencies, what we want to replicate in Arkansas is a community collaboration. And so, you know, obviously having Arkansas Blue Cross Blue Shield involved in that and this partnership is critical to that. They're here in the community, they've been here. We plan on having numerous staff that will be here in Arkansas working to, you know, in the field, working in the different communities to help the population. You know, we have always been collaborative with the medical community and with patient advocates, and frankly have always had very good relationships with the state, and plan on, you know, having a good relationship with the state of Arkansas, you know, if we were to win a potential bid that came out. And so those to us are the competencies that you have to have for Medicaid success. Now, I think the slide that I'm about to show right now might be a little controversial. So what I would say about the traditional value of managed care being financial savings, to me this is the bare minimum. And so what I would say is this: in the state of Tennessee, they have on their 2016 budget. So I know there's been a lot of questions about cost trend. And I know there were some slides produced yesterday and some this morning, you know, but what I would say is on the state of Tennessee's website, if we want to go look at the cost trend, they have in their 2016 budget presentation a sort of now and then slide. Basically shows the cost trend when TennCare started. It was about 13%. They were actually, their inflation percentage was about 13% when TennCare started. I think it was still in the double digits even as early as 2004. Here lately, though, the program's trend is about 3.3%, and that 2004 was right on the end of the implementation of the TennCare reform program, and so that's why the inflation percentage was still high in 2004 because of the reform. Then the reform initiatives kicked in, and that's when the state started seeing their lower inflation percentage. And so I think when you're looking at the state of Tennessee and what they're doing, looking at what they're doing now is much more important than what they were doing back in 1994. In 94, they had 12 or 13 plans. Many of them went under, and there were definitely some issues in the program. And now, you know, since then, since the reform initiatives, the program seems to be very solid and is moving in the right direction. And so, you know, and then from just a micro standpoint and cost savings, you know, in the LTSS population, and I think this is, I feel like this should go without saying, but we'll talk about it anyway, is that to care for someone in the nursing home, it's $55,000, basically. That's standard care in the nursing home, $55,000 in the state of Tennessee. It's $19,000 in a private residence. And so everyone who moves from a nursing facility into private residence, there is a savings of $26,000, and that is real. That is we have the numbers to back that up. The state has the numbers to back that up, and that's why they've been able to move more of their at-risk population into the program and care for more people. And that, you know, and so those are some of the micro savings that that you would see in an LTSS program. And so, you know, and I think one of the things I kind of like to talk about is just the autonomy that we give our care coordinators, and because it really is an in the trenches kind of program. And so, you know, one of our care coordinators.
Hang on, just push your button there,
Sure.
Senator Chesterfield.
Oh, sorry, my fault.
Maybe it's just process, but you're on page 7.
I am on page 7 now.
And
yeah.
you're going to do all 22?
No, I'm going to appendix. Yeah.
Not being, just process.
I understand.
I've got a plane to catch.
I got you.
It's getting late, but there's good and bad to that. But
I understand. I got you. Oh, I'll leave it at this. And then we'll have questions. So what I would say is that, you know, when they're in the trenches, there are all kinds of potentials for savings. And so one example is we had a member that had incredibly high ER utilization. Our care coordinator worked with that member, found that member was just lonely, needed some companionship. Our care coordinator got that member a cat from the animal shelter. That member never went back to the never went back to the emergency room. I mean, those are things that you can only do if you're in the trenches with the member and that you're working with them directly. So we'll, I guess, open it up for questions. And sorry for making you think that I was going to go through 30 slides.
okay, I guess I would ask, do you feel, so most of your experience with managed care is in, or all of it is in the traditional Medicaid population?
That's correct.
And the slide that you have there on page 6, when you say don't really think of it in terms of financial savings, my co-chair made a comment here, I just want to see if he's right. Are you saying that you take the savings and do what with them? You expand the program and provide additional services, or what?
No, I think that what we say is that that's the bare minimum for a managed care organization. Yeah, sure, we absolutely should be providing savings, but then in addition, we should be doing all of these other things to improve the quality of people's lives and to improve and to improve member satisfaction. And so to me, the bare minimum is financial savings. And
What you mentioned that in Tennessee, it's $55,000 per year per member in a nursing home.
Mm-hmm.
What do you think if I added up the liability insurance plus the legal tort? What number would that be out of the 55 grand? Is that 30,000 out of the 55 grand? Is that 40,000 out of the 55 grand? What percentage is that?
I'm not sure. So what you're asking is how much liability insurance do the nursing facilities carry for each one of those members?
Yes, plus whatever the judgments are. So like normally the way insurance works, as you know, unless you get reinsurance, you accept a part of it yourself and a part of it you insure. So there's two components to what you have to pay to cover yourself.
No, it's a good question. Tort reform's always been a hot topic in healthcare, and so
it is an item on the next meeting's agenda that Mr. Stevens is going to bring us some data on from other states and what impact that's had. Representative Ferguson, you're recognized.
Does the medical loss ratio apply to managed care companies as well from the Affordable Care Act?
The 85%? It did not apply to the Medicaid managed care organizations originally, but there has been guidance from CMS that says that they would like for it to apply in the future. So I do believe that we will be applying that 85% medical loss ratio in the future.
Is that any part of the TennCare or the?
It is not right now.
Do you all comply with it now?
We are probably slightly lower than 85%.
Okay. Do we have any other questions? That's all I have on the queue right now. All right, gentlemen, thank you so much for your presentation and the effort you put into it. We will be following up, I'm sure, with some more questions. We still have a couple other items and actually some important issues to talk about on the agenda, so I'm going to ask Mr. Stephen to come back down. We're going to talk, and Mr. Seelig, I think you might as well come on down. And John, while you're getting that pulled up, I've kind of got a general question based on all the presentations that we've heard here. One of the things that I think several of them mentioned was the ability to produce savings kind of depended on the state of the program when they began their efforts. It concerns me somewhat that we're sitting here with a program now that, John, would you say it was 2.5% growth in our current Medicaid program? So right now we don't have a program that, at least compared to some of the ones we've seen in other parts of the country, is growing dramatically. Now I know we've seen projections that that's going to increase, but I guess, do you feel that we have already utilized or reaped a lot of these benefits, and there's not as a field that's as reaped for harvest as there may have been in some of these other situations?
from our review, and the director may want to amplify, there's nationally a number of states during the past couple of years have been low Medicaid growth. So it's you're not that different. But when you look at your surrounding states, there are some that were even lower. So this has been a pretty good time, but there hasn't been a lot of innovation in terms of controlling costs at the department, because the department's tried to move into these high-cost areas and hasn't been able to. And those high-cost areas, remember a few years back, you were at 10 and 8%. So we're trying to tell you to think long-term in these 2 years. Like, for example, in Rhode Island, when they were mentioning yesterday that the cap in the waiver, because I happen to be one of the individuals that negotiated the waiver, was set at 7.5%, at a time when they came in the year of the waiver at 4% growth. That was a really good year for Rhode Island. They stayed within 4% for that next 5 years, even went down to 4.5%, 3%, during a time when the rest of the country was starting to spend a lot to, much more in Medicaid. And in fact, they went down in the negative numbers. So, the question is, are you going to continue to be where, the director has been in the past couple of years? We don't think so. We think a 5% projection is probably a reasonable one going forward. Because, again, that's the as-is.
Director Seelig, you agree with that?
Well, yeah, I'd agree with everything you'd said. And the other point, on the high-cost populations is, I think the money that we are spending, we're not spending well. I mean, we're not doing crisis services for people with mental illness despite how much money we spend. We serve too many kids and adults in inpatient settings when we could be serving them in outpatient settings, giving more support to families. So part of it, and some of these companies talk about that, part of it is making better use of the resources you have.
Okay. Before we start this, this has been passed out, hadn't filled the letter? No, it hasn't yet. All right, we're going to get a letter out to you. This is, and I say this because, John, you may want to comment on this. The co-chair sent a letter to DHS and also the insurance department when this re-verification started, asking about 7 questions with regard to how this was going to work and providers' reimbursements and retroactive cancellations, because there was so many different stories and rumors going around that we just decided to try to get it a direct answer. So I'm not going to go through this. Members, you can look at that. And I guess I did notice when I read this, there were several places where it said that DHS and the insurance department were working on agreements and processes to handle this. So you might want to address any of the gaps that you can as far as where we are with regard to our providers going to be asked to reimburse, and what situations are they going to be asked to be reimbursed? Have we seen any of that, or is it just in the cases that you stipulate here? Because again, I just want the members to be able to give a straight answer based on the best information we have, which is in this letter, plus whatever you might hear from the update. So why don't we just start with that, if you don't mind, Director Seelig, if you would comment on these questions that we asked and whether or not you have any update to the letter that you provided.
Yes, sir. Thank you. And I'm trying to find the letter now, but let me speak to the issue broadly. The question was, we do in the Medicaid program, when we do a determination of someone's eligibility, in some cases, some very limited cases, we'll do a retroactive termination. For example, if we find out, we've talked about these, if we find out that someone died in April, we'll actually terminate back to April and we'll recoup the premiums. If we find out that someone has moved out of state 3 months ago, we'll do the same. We'll recoup the premiums from the carrier. And the third case where we do that is if someone has indicated to us at an earlier date, say April 1, that I no longer want to be on the program. And because of the systems challenges we've had, and including the ability to make these changes, in some cases it has taken us a while to make those changes. So it might be in July when we actually take that person off the program. Our current policy says that we will also do a retroactive recoupment on the idea that if they said they didn't want to use the program, we probably shouldn't be paying premiums for those 3 months. There doesn't seem to be a big issue. Certainly with the people who died, you wouldn't think they're going to have any costs, so recouping that premium is not a big issue. If they moved out of state, it shouldn't be an issue, though it's possible they moved across the state line. But in either case, we really can't legally be paying premiums for someone who doesn't live in Arkansas. I think the biggest challenge has been for those people who indicated to us they don't want to be on the program. Then we have retroactively terminated them. For the carrier, in some cases, the carriers are saying, but they continued to use the program. So our current policy says we will do a retroactive recoupment, which we do, and that then raises the question, I think that really the letter was getting at is, well, so if you recoup from the carrier, will the carrier attempt to recoup from the provider, and will the provider attempt to recoup from the client? And I mean, it kind of creates a bit of a mess, which it does. That's something that we are going to relook at in the department, that third piece about if someone told us they're going to leave, particularly if they told us they want to leave and then it turns out they kept using the service, whether we ought to be recouping. That would take a policy change for us, which would need to come to the legislature. It's not something we can do overnight, but we think there's a reasonable argument for not doing that. Thus far, I am not aware that any carrier has actually recouped. At least one carrier, maybe more, have indicated they may recoup from the providers for the services that were provided. That then gets into an insurance issue of if the provider checked someone's eligibility, this might, so obviously I'm not the Department of Insurance, so I'm going to give you my understanding of it. If the provider checked the client's eligibility before providing the service and saw that they were eligible, state law or insurance regulation seems to say the carrier can't then recoup after the fact. What I've heard is there may be some issues where some providers may provide a service, not actually check the eligibility at the time, but just at the point they file a claim, they find out that they're not eligible, or they file a claim, they get paid, but they didn't check the eligibility in advance. I think that leaves some question open. That's what I'm hearing, but I'd really have to let the insurance department speak to the question of whether they actually can recoup or not. As I said, so far, I'm not aware of anybody recouping, and one of the things we're doing is we've asked the carriers, and I know at least 2 of them have given us list of clients that they're concerned about where we have done these retroactive recoupments, and we're checking to make sure those were legitimate recoupments and that they really didn't need to be retroactive like they were. So we realize there's an issue here. I don't think anybody's trying to hurt the other parties. We're all just kind of caught in this. And as I said, we're going to relook at our policies. We'll work with the carriers and the insurance department to see what's the most fair way to deal with this issue.
Okay, and again, members, we may want to have Director Kerr come over and talk to us at the next meeting about where they are, because again, I know this is policy that's still in development, but as far as you know right now, there's been no recoupments from providers in the situation that you're describing there.
Not that I'm aware of.
Okay. Okay, members, this last item is really just about the redetermination, eligibility, terminations, and so on. So why don't we start with Director Seelig, and then we'll let Mr. Stephen and his team comment.
I think there's the agenda before. We
What did I
have
miss?
The payment improvement.
Oh, yeah, go ahead.
Well, this one, and we wanted to make sure we updated you. First of all, the last meeting, you heard from the carriers, and you had asked us to meet with the carriers, and I think it was Representative Collins, on the wellness type programs that they have, healthy incentive type programs in the private option. So subsequent to the meeting, we met with the carriers. We found that 2 of the carriers responded that they had programs. Actually, one had a really robust program that we felt was very significant and could be something to use as a model to start looking at designing. It is a payment of, and it's Ambetter, that has a wellness program that they have like a credit card that they give an individual, and they put an account into the card when they begin the program. If they have the first visit to the PCP, they get a $50 payment into the credit card. If they take their children for immunization shots and show proof, they get another $50 put into that credit card. And then there's a couple other healthy reward points that if they meet those points, they get additional amounts. And that card is not cash that they can take with them, but it's a card that they've already done the automation and be able to use the UPC codes, so they only can purchase health-related goods. And I asked them if, from a technological standpoint, did it cost you a lot, and is it something that could be done if the task force wants a similar program? Does the task force have to go out and spend $8 million a year on a vendor to put this together? And they already have the system, and they felt it's not going to cost a lot at all to do something like this. So I just wanted to make sure you knew that that system is available. It's out there if you want them to come in and talk more about it. They were the only one that really had, at least from the responses back to us, and the interviews, and I did actual interviews myself, the best response.
John, thank you very much for that. Are you saying that would be legal to do with fee-for-service Medicaid as well, or is something like that only achievable in a private market insurance policy?
It's an interesting question, because we tried this in Pennsylvania. You can't do it in fee-for-service if you are doing it contingent on eligibility. You can do it in fee-for-service, so long as it's all done in a positive way, positive reinforcement.
So we could get preventative/wellness into traditional Medicaid and have some of that preventative side.
Absolutely.
Okay.
You could
Thank
have
you.
a health report card, you could do a lot with it.
Okay, Representative Ferguson, you recognize?
I really am fascinated by that concept, and I like it, because my problem that we've had Medicare Advantage programs, we've had insurance companies that require physicians and providers to do the management. And, you know, what I hear doctors say is, you know, don't make me somebody's mother. I can't make them go get a colonoscopy or this. So when you're putting it back in the patient's responsibility column, I think that's good. And I understand the private option Medicaid, there's no financial, you can't really take away anything financially, because they're not paying for anything. With private insurance, you can give them a cut in their their rates. But I like incentivizing good behavior with the patient and putting it in the patient responsibility column, instead of putting more load on these providers to make sure somebody goes and does what they're supposed to do responsibly anyway, just as a note. But yeah, who's doing that? Ambetter?
Ambetter.
Yeah, I like that.
And as you know, West Virginia in 2006 began to go down that road with Medicaid. And we're checking to see the results, but I think it all changed when the expansion started.
Okay, and the other item you had there was update on payment impact of episodes of care.
Yeah, and the one thing I wanted to just briefly state, the last discussion on the private option, because your interest was, it's fee-for-service. What would be the difference between a fee-for-service versus a private option, and we're looking into all that. And there are two states that I think really important that we're going to focus on. That is New Hampshire and Iowa. In New Hampshire, they started the private option in the fee-for-service. They have subsequently transferred that and put it into the managed care, complete managed care statewide. We are going to look at the PMPMs. We're asking the state to be able to give us information on what was the PMPM in traditional Medicaid, what was it in private option, or what is it today in managed care. The second state is Iowa, as I told you. Iowa started out with a hybrid model. They did 101% to 138 in it was managed care at the point of time. That's all they had managed care was private option. The less than 100 and below all went into fee-for-service. Today, Iowa has now started to move forward on full managed care. So they may have done some actuarial analysis on what that PMPM is. They're just starting it on the ground, and it's managed care for the whole program. So those are two states that we'll be able to identify for you the differences. But I want to caution you, when you look at these other states and look at PMPMs, it's not an apples to apples, because your population's so different. It'll give you an idea, but don't rely on it heavily, but it's important. And for example, Indiana has a private option just like you. Indiana's PMPM and private option is somewhere in the $260, $270 range. Does that mean Indiana's doing a better job care coordination than your state? It doesn't mean that. There's a lot of other issues you need to look at. And so just be careful when you start comparing those different models.
And John, I know you're going to look at this, and I hate to this late to bring up one more complexity, but when you look at the total private market for insurance, historically what has happened in the past is we step on the balloon and the air bulges out into that section of the market. In other words, I, the government, a dictator, can say, you will pay 1 penny for this person when they go to the hospital. The hospital then must accept 1 penny, and so they jack up the prices on paying customers. And so we can champion from the rooftops that as dictator, I'm only charging 1 penny for Jimmy, but Fred, Sue, Pete, and everyone else has to pick up the entire cost, and it is completely ignored as a cost in the system. So we have to take into account when we're comparing fee-for-service on Jimmy versus private option, private market on Jimmy, to also what happens to everybody else's insurance policy prices. Yep. So without that, it's not a fair comparison.
And to answer for example, in New Hampshire, as I know from my own home state, the regulatory aspect is so much more difficult than what your state is dealing with. So they have to put cost into that regulation. So it's going to be a higher PMPM, but the comparison that Senator Hendren's talking about as far as fee-for-service versus managed care, that's a good question, because I think you can get an apples to apples in a specific state, but be careful that it's not the same apples to apples to your state. And so, but your cost shifting, your regulation, Representative, is a big part of that issue, too. So,
If I can just add one note on that, Representative Collins, I think you're exactly right. I think what we're actually seeing in Arkansas is just the opposite in the last year or two. By bringing a lot of healthy people into the market, getting more carriers, and frankly not having as much uncompensated care, which does cause, for example, hospital to raise other people's rates. We're actually seeing rates flat and or dropping in Arkansas in the private market, I think because of what we've done, where around us, look at Louisiana and others, you're hearing of double-digit rate increases. So we seem to be having some impact here, which I think is a good thing. We need to certainly be, as we look for options to the private option, we need to take into account any impact we might intentionally or unintentionally have on the private side.
Okay, are you finished with that part, John?
yes, and Stephen's going to handle the payment improvement.
Okay, go ahead, Stephen.
Thank you very much. So these are just some informational items, updates on topics that have already been presented. At the last July task force meeting, we did present on costs and benefits of the payment improvement initiatives, particularly the episodes of care. After that, we sat down with the department and got some additional information on both the costs and the benefit side, and have revised our estimates a little bit. With the additional information about the estimates on the perinatal episode of care, we were able to refine the benefit side of it, and with identifying a couple of costs that we had included on the cost side of the ledger that were not, in fact, development costs, were more ongoing operational costs. We were able to refine the cost side. So at this point, our estimate is that the first 14 episodes cost about $3.5 million per episode to develop, and that develop and deploy, and that the average savings range for those episodes was between 0.6 and 1.5 million annually, leading to a revised average payoff period of between 2.5 and 5.5 years. And we're still working on the ongoing operational cost. Any questions on that?
So you're still saying, or you're saying now about 2.5 to 5.5 years payoff on each of the episodes of care?
On average, yes.
And I guess what I would ask you, how does that fall in line with efforts that other states have made or that you would expect in the industry?
I have not seen in any other programs that can be compared in an apples-to-apples way.
Okay. Representative Ferguson, you recognize?
I know you can't tell me a detailed explanation of the expense, but that includes the grants, what, 120 million that we paid to McKinsey or the groups to create the program to monitor episodes? I mean, give me the big five expenses.
It's really big three. And it's the costs to McKinsey to provide assistance with development. It does not include all of the costs to McKinsey because some set of the activities that McKinsey was involved in were not directly associated with the episodes of care program. Some were associated with PCMH, and some were associated with the development of the RFI for the high needs populations. It also includes more technical and operational costs through the MMIS vendor, HP, and GDIT, another technology vendor that they use to actually operationalize the episode payment side of things.
I can't. Oh, there we go. Okay, just give me a little breakdown. That 3.5 million is all the development cost for the episodes.
Average. That's the average across those initial 14.
The 14. And just what percentage of the Medicaid budget relative?
I don't have that number in front of me, but taking into account the grants that were 100% federal, some non-Medicaid costs, and then some chunk of it, which was at the administrative matching rate. If I recall correctly, it came very close to the normal breakdown between state and federal, about 70% federal.
Yeah, I mean, I know it's federal, but I guess my point is you spent almost half as much as a percentage. What do you pay physicians? 6% of every Medicaid dollar? We've spent almost 3% of every Medicaid dollar developing the system. Is that?
Yes.
Let's get on.
Representative Ferguson, I believe it's far less than that, and that's largely kind of one-time cost to get this going. I mean, over time, it'd be even less than that. It's just a fraction of our Medicaid budget to do this. As I said, I mean, I would say a 2 to 5 year return is pretty good on just about any investment. So again, we've got challenges with it, but I think it's been pretty successful.
Representative Gray, you're recognized.
Thank you, Mr. Chair. I'll just make this quick. I just wanted to reiterate, I just want to make sure that you do come back to us with the annual operating costs, just so that we make sure that the 2.5 to 5 years isn't really 15 or 20. We never actually get it paid off. We'll be doing something different in 5 years anyhow. It's not your typical rate of return. So just wanted to reiterate that. Thank you.
Okay, let's move on now to the eligibility and re-verification thing. John, why don't you give us an update on that?
And there's one more update slide on the survey.
Okay.
Y'all had asked to just-
Are these slides in your original packet of stuff you gave us?
Yeah, they should be
Okay.
at the very end.
Okay.
And this is just quick.
The last one.
Yeah.
All right.
Y'all had asked for an update on the survey. This is a provider survey primarily about the payment improvement initiatives. As of the last task force meeting, we had received 250 responses. We've now received 438. The breakdown across provider types and specialties looks pretty similar, as does the breakdown across the range of opinions expressed. We're going to leave it open through the end of this month and then close it for the final analysis, and that'll break it out across a number of the different axes that y'all requested.
And that's 438 out of how many?
Well, the total number, it went out to all of the physicians and hospitals in the state. So total number of providers is between 3,500 and 4,000.
Okay. Okay. Now you're up, John.
All right, thank you. Well, Senator, I'll keep this very brief and answer questions because I know obviously the governor's had some press conferences, has sent you all letters. I think the last meeting I discussed the process for redeterminations. I can tell you, we will be doing about, I think our estimate is about 590,000 people that we'll be doing redeterminations on. Thus far, we've begun the redeterminations on about 400,000, so we are well into the process. About 70,000 of those have been renewed. About 50,000 of those have been sent notices of termination, most because we've not yet heard back from them. And then we have, really in the last week or so, reinstated about 2,500 people. I think you're all aware of kind of the steps we've taken to increase our capacity, to move more quickly, to catch up on the backlog we have, much of which the governor approved, and we're putting those things in place. So if you want me to, I can walk through those, but I don't want to, I know it's late, and I think you all have probably heard that. I'd be happy to answer any questions or go deeper wherever you want to.
I guess the question I would have is, based on the trends that you're seeing, you're at 50,000 terminations now, 70,000 good, and I guess you've got a whole bunch there that are still in process.
Right.
What do you expect when you get to the 590,000, if the trends continue as they are, the total number of terminations to be?
Well, let me say, I don't think the trends will continue as they are. I think the populations that we have yet to do or that haven't come in are more likely to be eligible. For example, there's a whole lot of kids that are out there and people who are at income levels or who are, for example, also on the SNAP program, where we know because they're on the SNAP program, they're income eligible. It would be tough for me to hazard a guess. If I have to, I'm going to guess that at least 70,000 will receive notices of termination, probably more, but I think a significant number of those will come back on. We're now starting to get a lot more people coming back to us, say, here's my information. And in some cases, we have their information. We've been focused on making sure that we're not cutting anybody off because we frankly didn't get a chance to open the mail and get them in the system. We're now able to actually work more of those. So, the governor estimated on the private option, he thought we'd end up at about 220. I think that's as good an estimate as anybody has at this point, but it could swing wildly from there. In part, and I talked about this last month, we just don't have any experience from other states to know. I mean, I think we're going to be 2 or 3 months out before we really have a good sense of who ends up remaining on the program.
Do you have, and I know this was something that was addressed at the press conference, but you feel comfortable that the staff and the processing time that you all have now to handle the re-verification paperwork that's coming in is sufficient to make sure that we don't terminate people because we couldn't get the paperwork processed?
Yes, sir. Okay. Yes, sir. Just to be clear, I mean, there's lots of paperwork we have, but none of those people are getting terminated until we have a chance to process it.
Okay. Any other comments from the Representative Ferguson?
I know there was some problem. I'd heard some pediatricians about the newborns getting on and they weren't on in 45 days. Has that been resolved?
I am happy to tell you that IBM has finally given us the component, the coding, whatever you call it, the software. We are now in testing. We obviously don't want to put anything into the system until it works. I think that's going to take, I'm going to look back here, I think about 2 weeks to do that before we actually implement it. Moving around. Is that about right? So in about 2 weeks, that should be good to go, and that it's specifically designed to address the newborn issue.
Thank you.
Okay. John, would you like to comment on this at all?
We've worked closely with the director and his staff, and I know that Jason from our team are eligibility experts here, but I don't think there's anything extra other than that time notice. We do feel, and we put it in our status report, we have the citation, the statute citation, and done some research that the 30-day notice is what we feel, through our discussions with CMS, is probably appropriate in terms of the language in the statute.
Okay.
So I should probably respond.
And we've been working with the
Right.
department, so very well.
So for redeterminations, what's kind of a standard redetermination, what's required is 30 days. We are not doing, but that standard redetermination requires that you send out what's called a pre-populated form and ask people to to give us lots of information if they want to. That component is not, that form is not in our system yet. And we worked with the federal government, and there's another state doing the same, where in this round, we're focused on what we think is most essential, which is the income verification, making sure they're income eligible, not sending a form that says, do you want to tell us somebody new's in your house or that you moved or whatever. Income verifications in Arkansas for years, at least 20 years, we've always given a 10-day notice. So for this income verification, we're given a 10-day notice. We are on at least weekly calls with the federal government, and they are not raising a concern about our 10-day notice. That's not to say, I mean, we can certainly argue whether more than 10 days would be good. We think that 10 days is working, and we think if there was a real concern from the federal government on one of these weekly calls, starting back months ago, they would have said, we're uncomfortable with that. So we feel comfortable that what we're doing is allowable, given that we're not doing a full redetermination.
Okay. Representative Flowers, you have a question? Push your button there, that green one.
Thank you, Mr. Chair. My question is about what the status is of those who were sent letters and they were among those who never received them, and they actually came back in all of those crates of mail that were, letters that were returned to you unreceived or to DHS unreceived. What's happening to those folks?
When we get something returned to us, it comes one of two ways. Either it'll have a forwarding address on it if the post office has one, and we'll then send something to the forwarding address, or it will come back as undeliverable. If it comes back as undeliverable, if we have something in the case file, some other way to contact them, we'll try to do that. But otherwise, I mean, it is the responsibility of the client to tell us when they move.
Right.
And we just have to terminate the case because we don't have a way to follow up with them if they have not given us a new address. Now, I will say, let me add to that. In some cases, the insurance companies, for people on the private option, have given us what they've found to be what they think is a better address, and we will send something to that new address and see if that works.
Thank you. And Mr. Chair, if I could just do one quick follow-up. And also I'm wondering, and I apologize if this has already been asked and I was out of the room, what about those who may have been terminated because they may have sent the information back because of lag time due to mail or the processing time where you all didn't realize you had the information? what's happening with them and how long will it take to get them back in the appropriate, in the eligible status?
So we did have some of those, and that's why we did the 2-week pause to make sure we caught up and didn't have anybody who had mail into us that we hadn't processed in time and was bumping up against the deadline. For those people, we are now working those cases, and what we've told providers and others and certain legislators who've asked, and when we get calls, I mean, if there's someone who has returned information to us and we haven't processed it yet, give us a call, let us know, and we'll kind of pull them out of the queue and work them more quickly. So if you know of somebody, I mean, please, you can let me know, someone else, and we can work those more urgently, because there are people, I mean, we're getting a lot of material from people who want to be reinstated, and the counties are just trying to work that as quickly as they can.
I will.
Okay.
Thank you, Mr. Chair.
I'll count on it.
Senator Ingram, you're recognized.
This is directed, thank you, Mr. Chairman. This is directed to Mr. Stephen. I've wondered, in business, you would take a sample size. You would not force feed 250,000 people. I mean, the DHS is drinking out of a fire hose. In an audit, you would take a sample size, and if there was a deviance that was there, you would pursue that further, or you might take it over a period of time, not all at once. I'm just wondering, across the country, in your experience, have you ever seen a state try to do what we're trying to do in this redetermination, take this whole sample just all at once?
I haven't, in my experience. It doesn't mean that there isn't. Most of the state redetermination process is done in a seamless, continuous continuity way, or continuous way, so that individuals all at once don't inundate the state because they don't have the resources. And I can tell you the Director Sealig's staff is working overtime, and we're trying to get questions answered for you folks, and they can't get back to us right away because it's more important for them to focus on the duties, and they're even bringing people in overtime. So yes, a better way is to do it in a slow, methodical, audit type methodology, but there could have been other reasons and we weren't here when that all was decided, so.
Well, Senator, and we certainly, I mean, our normal process is over the course of the year, as someone becomes eligible, we actually start a couple of months early, giving them notice. What we ran into is because our system couldn't do redeterminations, we got backed up months, and the federal government, we got a couple of waivers from them, but they said by October, you will have initiated all of these. So that's why in about a 3-month period now, it's a mess having to deal with it now. And certainly our intent is to then find a way to spread those out in the future. We do not want to do all these in a 3-month period in the future.
Thank you, Mr. Chair.
And what is the deadline that we have to have all this done to satisfy the feds?
September 30th to initiate all of them. They realize some of them may take longer as we go back and forth.
So that won't be a problem now?
I don't think so. We're 2/3 of the way into the process now.
Senator Chesterfield.
Thank you, and I'm certainly not going to stand between us and adjournment, which will be soon. But I do want to ask, well, first let me say something nice to you, John. You are one of the best multitaskers I've seen, because the greatness of the work within DHS, and no matter what committee I've seen you in, whether it was Children and Youth or this one, you always are prepared, and I wanted to say that to you publicly.
Thank you. I have a lot of help.
I'm sure you do, but most folks can't remember it all, even when they have help. But are we working then with DWS and the other agencies, Social Security and those other agencies, are we able to partner with them so as to re-verify, because people are going to get those checks? So is that what we're doing?
Yes, ma'am. Who we work with now is Workforce Services. We use their wage data to verify. And one of the challenges we have, and I don't know if we've talked about in this committee, what we're required to do is look at the data on file, in other words, what the client has told us or what we found out last year, and then compare it to this new data source. When we go look at Workforce Services, the wage data, which is much more current than IRS data, so we like using it. If there's no wage data there, all we get is a blank back. So we don't have anything to compare, and that's when we then have to go to the client. I mean, a lot of them, as we've talked about, probably have no income, but we don't know that because we just got a kind of a not applicable. And one of the things I'd like to look at in the future is there are some way to get at that where if there's some way to determine somebody truly has no income, that we don't need to go verify with them. We just need to figure out what it is. And then, of course, we'd have to make our system do that. So it's a concern of ours. But that's what we're doing now. I would just also say with Workforce Services, not so much on the data, they are going to give us at least 100 of their TANF clients who need work experience to help us do this processing. We're finalizing the MOU now. We think that works well for the clients, for us, for them, so we're very excited about that.
Me too. Thank you, Mr. Chair, and John and company, thank you all for being back. So are you losing weight, John?
Do I need to answer that?
Okay, that's all we have on the agenda. It's been a long 2 days and a lot of good information. I think Mr. Co-Chair wants to say a few things, but I appreciate everybody sticking around.
I just want to talk about the upcoming meetings, because, you know, where we are now is we're getting into this recommendation phase, you know, thinking through recommendations. You know, John's going to be leading that. So as you get those, or you talk to people that have recommendations, I would strongly encourage you to get that to me and Jim so we can get it over to John, because here's what I don't want to have happen. We're going to have a real crunch time in October timeframe, and then if John comes and says, you know, here's the spectrum of recommendations we're looking at, what I don't want us to then say to him is, hey, has anybody thought about this brand new thing? We need to go talk to this group of people and start from scratch on. Start bringing that stuff now so he can vet through that and go from this preliminary report he gave us this week into his final report that's going to be coming on the 1st of October. Now, here's the challenge that we've got on meetings. September is bad for lots of reasons. We're going to lose our co-chair in September, and so I had us circled around toward the end of the month to meet, but we've got lots of conflicts there, people leaving the country, people going to Fort Smith. So I think what we're going to wind up doing is having multiple meetings in October and early November. So I would just say get ready for a very aggressive October, November, and then I'm going to try and twist some arms and get us this room, because a room is taken by everybody all the time, and see if I can nail 3 sets of 2 days between October and early November. So that's the goal. Thank you all, and we're adjourned.